Welcome to the first of a number of infectious disease blocks. Here in this first block, we're going to review just the principles of infectious disease management as it relates to pharmacotherapy. And throughout these slides, as we had in some of the earlier slide decks, you'll occasionally see a 747, which is a somewhat detailed slide, and I'd encourage you to focus more on the bigger picture than the detail. There's only a few of these slides in the next one or two slide decks that have the 747. The remainder of the curriculum is probably not going to see too many of these, but this gives you the sense of when you need to focus on the bigger picture. And we'll start to get more granular and more detail-oriented pretty soon. So as we alluded to, just focus on what you think are the big pictures when you see these slide decks. So let's first look at what we're going to talk about in this first of 4 slide decks. We're going to talk about the principles of infectious disease, and we're going to describe the relationship that the microorganism, the host, and the drug have a bit. That should have been covered also in some basic microbiology. We'll talk about principles of drug resistance a bit, and we'll differentiate some of the principles we think about with normal flora versus what's not normal flora, and talk a bit about that. We'll talk about classifying drugs. We classify them as antibacterial, antiviral, antifungal. And when we look at the antibacterial drugs, we look at their mechanism of action and also their chemical class. And also we differentiate those that are what we'll call bactericidal from bacteriostatic drugs. And that's an important principle to keep in the back of your mind as we approach which drug we use for which condition. We'll talk about some of the adverse effects we see with anti-infective drugs and how we try to minimize those effects. We'll also talk about the way that we monitor effects with patients. We'll also introduce the ideas of antimicrobial stewardship, where we really need to be careful and judicious when we use anti-infective drugs and consider times when we should wait before we institute antibacterial or other antiviral or antifungal drug therapy. So a key principle in infectious disease management is to recognize that the host and the pathogen have in a sense, a relationship. And if the host has an intact immune system, if the pathogen is not particularly virulent, the host may be able to, without the use of antibacterial or any drug therapy at all, be able to eradicate that pathogen or at least keep that pathogen in check. What our approach when we add drug therapy is to find something that renders the pathogen or the bug either killed or inhibited in some way, but we also hope that that drug has minimal or no effect on the host. So really the ideal antimicrobial agent would be something that would be lethal to the pathogen we're trying to treat and yet have no effect or be inert to the host. And we're going to play into some of the differences between our cells and the bacteria or the virus particle that will render that pathogen vulnerable where it would not, where if we targeted that vulnerability, it wouldn't affect the host in a negative way. So we think about it, let's first differentiate bacteria from viruses, which I think you're pretty familiar with. Just think of viruses as very large, or comparatively large at least, and they live on their own, where viruses are really nothing more than strands of DNA or RNA in an envelope of some kind, and the virus needs to go in and use the cellular mechanisms of the host to replicate itself. So when we think of major microorganisms, we look at the structural differences of whether viruses have no cell. That makes viruses actually difficult to target. We have some strategies we'll talk about with antiviral therapy later in these blocks a bit, but we're somewhat limited in what we can do there. Bacteria are prokaryotic, and then fungi, algae, and protozoa are eukaryotic. And often fungi, algae, or protozoan infections, because they're a little more like our cells, it's a little harder to find broad spectrum therapy or effective therapies for those conditions that aren't necessarily toxic to the host. But we have ways to do that. We have a couple of agents we'll use in some circumstances that are not very toxic. Others, particularly a particular antifungal we'll talk about briefly, is very toxic to the host cells. And then bacteria fall somewhere in the middle, and we're going to look at what are some of the differences between the bacteria and us that could serve as a target for that pathogen. So we look at these differences of prokaryotic versus eukaryotic cells. We look at cell membranes, if they have a nucleus, cell walls, and internal organelles. And the focus are going to be for some of the bacterial cells, we're going to look at bacterial cell wall as a target. We might find that there are membrane targets, but we're also going to find that sometimes there's some other factor associated with the pathogen that's a little different from human, and that could serve as a target for how we might target that pathogen without harming the human host. You're familiar with gram staining, I trust, from your microbiology coursework. And basically what happens here is that we find and use a dye and then a wash process to determine whether or not the bacterial cell wall picks up or doesn't pick up a stain. And so we'll find that when we that gram-positive versus gram-negative bacteria will stain differently. And in fact, we'll use that often in therapeutics to initially identify a pathogen and narrow a spectrum of what we're trying to hit against or target against if we got an initial gram stain of that pathogen early on. There are a great number of bacteria, and we're going to focus mostly in therapeutics on antibacterials, but we also have to focus in some cases on antivirals, antiretrovirals for HIV, for example, and antifungal therapies as well. But in bacterial cells, let's look at some of the relatively common pathogens and where we may find them. But before we actually do that, let's just take a moment and think about what in the body is sterile. And so I'm going to talk about a normal, healthy person. If I talk about a particular body fluid or body area, I want you to think for a moment, should this be sterile, or is this have some bacteria on it? So let's first look at skin. Does skin sterile or not sterile? Okay, you thought about that for a moment. Of course, it's not sterile. The more common pathogens we see in the skin are staph and strep, some of the gram-positive pathogens that you'll see there, but some of them just live ubiquitously without causing infection. Okay, let's look at the lungs. Sterile or not sterile? You would expect that the lungs would be sterile. In a circumstance where you have parenchymal tissue that is infected with a pathogen or a set of pathogens, that would be, among other things, pneumonia. And so what are some of the pathogens we might see with pneumonia depends on the patient themselves and what some of their risk factors are. For example, if they're a smoker, then one of the gram-negative pathogens that is more common in smokers is Haemophilus influenza. For many younger patients who have community-acquired pneumonia and present with it, they may present with an atypical infection. An atypical might include chlamydia or maybe some of the mycoplasma. If you have a hospital-acquired pneumonia, you may be very concerned about a gram-negative pathogen far down on the far right list here, Pseudomonas or Pseudomonas aeruginosa. Okay, let's switch now to the urine. Is the urine sterile? Is the bladder sterile or not sterile? Ideally, it should be sterile. a fair number of people have colonized bacteria in their bladder, in their urine, and some folks actually have a rip-roaring infection. For the most common pathogen we see in the urine is the gram-negative pathogen E. coli, Escherichia coli. E. coli, very common. We see in community-acquired urinary tract infections, particularly in women who have not had instrumentation done. But if they are self-cathing or they've been catheterized, then a lot of these other gram-negative pathogens could come into play. We could expect to see Proteus, for example, pretty common, Morganella, perhaps, Citrobacter, Acinetobacter, and the one we worry about the most is Pseudomonas or Pseudomonas aeruginosa. Okay, what about the blood? Sterile or not sterile? We would expect, of course, the blood to be sterile. And when it's not, it's considered a bacteremia. And the kind of pathogens that can enter the blood pathogen could be found from any other source. So, for example, you may have a source from a pneumonia or from a urinary tract infection or from a skin infection that seeds the blood, and then the blood becomes infected as well. And that could really be any pathogen, but it's more likely to be a particular pathogen based on where the source is. So, for example, a patient who has IV drug abuse, who uses IV drugs without a clean needle, might be expected to have a whole host of pathogens, but some of the more common ones are staph and strep, particularly strep viridans. And you could also see some of the other pathogens as well. Proteus, for example, could be one. There could be a host of other pathogens that could fall in the list, almost any of them, really. And the risk for someone, for example, who's IV drug abuser, who then injects with a dirty needle, the concern is going to be that that pathogen could end up on the valves of the heart and end up with a risk for endocarditis. So when we look, it's going to be important to know when we think about therapeutically, we think about what the pathogen is. We're going to look at, well, what's the source? What's the history of the patient? And that's going to suggest to us what the likely pathogens empirically might end up being. So some of our principles of antimicrobial therapy are recognizing that a lot of patients we're going to see, particularly in the hospital or in community practice, will have an infectious disease for which they need antimicrobials. We're going to look at susceptibility testing. We're going to get cultures whenever we can. We're going to focus on how to use agents properly but not. You'll often hear these terms used interchangeably: chemotherapy, antibiotics, and antimicrobials. Chemotherapy, when you think about chemotherapy, your first thought is probably a cancer patient and the treatment we use for cancer. But actually, chemotherapy is considered any treatment of something that is not us, that is an invading organism. And that could be infection, or that could be a cancer growth of some kind. So you'll sometimes hear the term chemotherapy to refer to antimicrobials. An older term, antibiotics, antibiotics refer to chemicals that are produced by a microorganism that has the ability to harm other microbes. And so really the first widespread antibiotic that we think of often is penicillin. Penicillin is derived from mold. It's a product of mold that actually has antibacterial properties. So that's considered an antibiotic. In this day and age, though, particularly in the community, patients, lay terms, will often talk about antibiotics as any drug that is used to treat an infection. Usually when clinicians talk about antibiotics, they use the term loosely to mean antibacterials. A more precise term is an antimicrobial, and then subset is an antibacterial antimicrobial. Is it antiviral antimicrobial, or is it antifungal antimicrobial? We focus in therapeutics on looking at selective toxicity. So we're looking at something that is different about the bacterial cell from us. It could be inhibition of the cell wall synthesis. We see this as a mechanism, for example, for penicillins. We can look at inhibition of protein synthesis, tetracyclines can do this. The macrolides we'll talk about can do this. The aminoglycoside antibiotics can do this as well. We might look at a disruption of cytoplasmic membranes. Polymyxin and some of the antifungal drugs do that. We look at inhibition of a metabolic pathway, something that's different from us versus them. For example, we require folic acid for cell function, but many bacteria make their own folic acid, and we can inhibit the pathway of manufacture of folic acid in patients who are infected with some of these pathogens by using a sulfa drug or trimethoprim or dapsone. We can also look at inhibition of DNA and RNA synthesis. That's used in some antibacterials as well as some antiviral drugs we'll talk about. Or sometimes there is some technology that's looking at how bacteria may attach to or recognize the host. In common practice now, there aren't a lot of drugs that we think about that. There's one HIV drug we'll talk about a little bit later in HIV. The classifications of antimicrobial drugs, we classify them in really two different ways. We think of them as what's the susceptible organism. So the broader terminology, we think of antibacterials, and then we'll talk about antivirals and antifungals. We can also think about the mechanism of action of all of the antibacterials. We have the beta-lactams that affect the bacterial cell wall. We think about the cephalosporins that affect the bacterial cell wall. We have other drugs that affect the bacterial cell wall, like vancomycin. We have other drugs that affect some protein synthesis in the cell, so those classes, we can look at the fluoroquinolones, we can look at the aminoglycosides and such. And so you'll see our classification as we talk about these drugs in the next couple of slide decks. We'll sort of expound on that a bit. We also think about which pathogens are involved. Is it a narrow spectrum or a broad spectrum agent? And narrow spectrum or broad spectrum. Narrow spectrum, as you can imagine, only target a few pathogens, where a broad spectrum is like a cannon. It targets a lot. The advantage of a broader spectrum agent is that if you don't know what you're shooting at, your cannon is likely to hit it. The problem with broad spectrum is that you can affect other normal flora. For example, normal flora in the gut could get disrupted, and so you could lead to an infection of something that isn't hit by this pathogen, but has now all the nutrients available to it because you've wiped out normal flora that are competing for those same nutrients. We also think of the agents, whether they're antibacterial, as we alluded to, antifungal, or antiviral. So let's look at some of the mechanisms of action again to reinforce what we talked about a couple of slides back. We can have antibacterial drugs that inhibit bacterial cell wall synthesis, or membrane permeability. We see this with one of the antifungals in particular. We can affect bacterial protein synthesis, either in a lethal or in a non-lethal way. We can inhibit synthesis of nucleic acids. We can affect metabolism of some point in the cell, in the bacterial cell, or we can have inhibitors of viral function, viral enzymes. Let's spend a minute talking about the minimum inhibitory concentration and what this means for us in practice. We'll use this concept actually to try to identify in a targeted way when we have identified a particular pathogen from a culture, whether or not that pathogen is susceptible to a particular antibiotic and at what dose or what level that's true. So typically what will happen is that once a pathogen is identified from initial culture, this usually takes 24 hours, 48 hours into the culture process, is that pathogen is then put in increasing dilutions of increasing concentrations of different antibiotics. And so in this example, let's say this is penicillin and this is a strep infection. So the strep pathogen would go into concentrations of 1, 2, 4, 8, 16, 32, and 64 in that 64 milligrams per liter, for example, of the antibiotic, but it's also in an agar or in a growth medium, but with the growth medium having that antibiotic in place. And then it's incubated for a period of time at a warmer temperature that would foster bacterial growth. And then after 24 to 48 hours, they will look at which concentrations of the bacteria growing in. And so in this case, we find that once we get to the level of 16 milligrams per liter, at this concentration, at 16 milligrams per liter, this is considered the minimum inhibitory concentration at which we will inhibit the growth of bacteria. And how is this done actually is that in this tiny little tube of broth that's got a concentration of antibiotic in it, they will put a beam of light through that tube, and if it bends, it indicates it's bacterial growth. If it doesn't bend, it won't. The 16 in this case is an example of the concentration at which the bacteria inhibits further growth of the bacteria, but you'll still see that the bacteria is alive. It just doesn't grow. The minimum bactericidal concentration, the concentration at which it kills bacteria, in this case would be 32, one to the right. And so the MIC, the minimum inhibitory concentration, guides us to tell us, hey, if we can achieve this concentration at the site of infection, this drug has a reasonable choice for being effective as a treatment. If we could get a concentration of 32 or 64 at that site, that's all the better, because that's bactericidal. That'll not only prevent replication of the bacteria, but will actually wipe it out. And so many times what you'll find is that you will get a culture done, and let's say it's a culture in urine. You got a urine culture for somebody with a urinary tract infection. The lab will tell you then after 24, after 48 hours, 72 hours, when the culture comes back, they will have done some of the work for you. Now, they may tell you what the minimum inhibitory concentration for 6 or 8 different antibiotics is in that urine sample, but to make it easier for you, they've already identified what the likely levels of that antibiotic would be excreted in urine for the typical doses that are used for most patients. And if they've achieved bactericidal concentrations at that level, they will consider that antibiotic susceptible to that pathogen susceptible to that particular antibiotic. If, in fact, it's closer to this minimum inhibitory concentration, they may call it intermediately sensitive, meaning that you really have to get a higher level, maybe use a higher dose, or consider a different antibiotic because it's a little iffy about how effective that's going to be. And if, in fact, the bacteria grow at the concentration that we could achieve in that urine sample, they will consider that pathogen resistant to that antibiotic. You will also find in a blood culture, they'll do the very same thing. In a blood culture, they'll give you whether it's sensitive, intermediate, or resistant. But in that case, the level or the breakpoints they decide on are what would be achieved in the blood. For the sputum, if you had a sputum sample, they're going to do the very same thing. And in a sputum sample, if they grow out a pathogen, they're going to tell you whether it's sensitive, intermediate, or resistant. But they may use a different breakpoint based on what levels that antibiotic gets in that particular area, particularly in the lungs. So depending on where your sample is from, they may choose a different breakpoint based on what concentration they have, and we'll tell you then if it's sensitive, intermediate, or resistant. But we often will use the MIC, the minimum inhibitory concentration, to help guide our therapy, particularly when we're stuck. If we're in a position where we have an intermediate result of the only antibiotic we've got, you may in practice have to call the lab or work with your clinical team to call the lab and ask them, what is the MIC for this pathogen? And then work with the pharmacy to try to identify at what dose you can give, at what dose do you need to give to achieve that level in a safe way. As we've kind of alluded to, drugs can be bactericidal or bacteriostatic. Let's first talk about bacteriostatic. Bacteriostatic the concentration that's typically achieved for that drug would typically prevent the drug from replicating, but wouldn't necessarily kill the drug that's there. You could consider bacteriostatic drugs as, in a sense, birth control for bacteria. So bacteriostatic drugs are drugs that will, given the choice between bacteriostatic and bactericidal is what we want, really. That's what's going to kill the bacteria. And at almost all levels, if the pathogen is sensitive, it's going to just wipe it out. It's not going to allow the bacteria to grow at all. And bactericidal drugs are particularly more advantageous if someone's immune system's a little bit compromised. So all things being equal, if we had a choice of 5 or 6 different antibiotics to use, particularly in someone who has immune compromised status, then we would prefer to use a bactericidal drug over a bacteriostatic drug. That said, you will find that some drugs in lower concentrations might be bacteriostatic and in higher concentrations might be bactericidal. So this is kind of, in a sense, almost an artificial depiction of whether a drug is static or cidal. But we would prefer using, in someone who's immunocompromised, a bactericidal drug if it were the case than a bacteriostatic one. Many times, however, you'll say, well, if we have bactericidal drugs, why do we even use bacteriostatic drugs? That's partly because the penetration of these bacteriostatic drugs may vary based on what site. Do they get to the site of infection well, depending on the pathogen? Do they cover some pathogens better than others? And so those are all going to be considerations for us as we think more specifically about some of these common agents. If you look at another way to think of this, bactericidal drugs kill the organism. So the concentration of the bacteria goes down dramatically, almost to nothing, when you use a bactericidal drug. At a drug that's bacteriostatic, or at the concentration we use is bacteriostatic, this slows the growth or division, but really requires a little bit more of the host's immune response to mop up things. And so you'll see the concentration of bacteria is reduced, but is not sort of going down towards zero. Another consideration is where the period of killing is, and this depends, in fact, on which drug we're using. So most bacteria will be bactericidal while your blood or tissue levels where the bacteria are residing are above the MIC, or really the MBC, the minimum bactericidal concentration. And then once that the levels get at the site of infection get below that MBC or MIC, then you'll see that the antibiotics don't work. And so here's an example where penicillin, which works on bacterial cell walls, will be killing the bacteria as long as the concentration is above whatever that MIC or MBC concentration is. And then when you get below that, it doesn't work anymore, which means that in this case, after about 6 hours, in this example, you would have to redose the penicillin for it to be effective. Many times we have to redose when we fall below the MIC. There are, however, a couple of drugs, different drugs, that you can actually see bacterial killing continue beyond the point where the MIC falls off, the concentration falls off and gets below the MIC. Examples here are the aminoglycoside antibacterial drugs, gentamicin, tobramycin, and the pretty commonly used fluoroquinolone drugs, ciprofloxacin, levofloxacin. Here's why. These drugs don't work on the surface of the bacteria. They actually penetrate into the bacteria and will continue killing because the concentration in the bacteria is higher than what it is outside in the blood or in the tissue. And so they may continue working. An advantage of these drugs is that you don't have to dose them as frequently. You might be able to dose them every 12 or 24 hours or sometimes even longer, depending on where the site of action is and if they continue to be bactericidal, irrespective of the minimum inhibitory concentration. So when you look at a monograph for different antibacterial drugs, you may find a typical regimen, and that regimen in part is related to the kinetics of the drug, how it's absorbed, how it's distributed, how it's metabolized, how it's eliminated. But it also, for antibacterials, will look at this period of in either inhibition of bacterial growth or bactericidal activity, and that might extend beyond the when the levels get below the MIC. So just keep that in mind, that a monograph's going to kind of build those regimens in part in. We also have to think about the concept of antibiotic resistance and how antibiotic resistance happens. There's a lot of resistance that can happen based on the antibiotics that we choose or use. If there are a lot of bugs around, there's not a lot of drug resistance. But if the antibiotic kill good bacteria as well as bad bacteria, anything that's left will have all the nutrients available and will allow it to grow and take over. And the ones that are going to grow and take over are the ones that can live in the medium of that drug. And so that's, in a sense, how drug resistance to antimicrobials happens. How that resistance spreads can be done either in use of antibiotic-laced animal feeds, and so I think in the larger culture at large, we're seeing a lot more consumer awareness of using, for example, if folks eat meat, to consider antibiotic-free sources of meat as opposed to antibiotics that have historically been used for the financial gain, for example, of that industry. Also, though, we see that the resistance spreads, particularly in healthcare settings, when clinicians can transfer from one patient to another. And the biggest campaign you can do, and probably the one activity, you can guess what it is, that is more effective than any antibiotic, is washing your hands. Washing your hands well, learn how to do it well. Wash your hands before you go in to see the patient and after you examine the patient, both before and after. Good soap and water, mechanical 20-second hand washing before and after is ideal. In clinical practice, if the patient doesn't have a particular pathogen or risk for a pathogen called Clostridium difficile, we often will see in healthcare the easier to utilize alcohol sanitary wipes, and you see those really everywhere. You see them in airports, you see them in stores, you see them lots of places. But really, it doesn't replace good hand washing, which is really ideal to prevent resistance. Some of the things that we think about in practice, acquired resistance, are due to some changes that the microbe may make in the presence of the antibiotic. They may develop enzymes that metabolize the drug, and so they can live with it. They may find a way that a strain or a further developed pathogen over time can have developed the ability or morph into the ability to cease uptake of certain drugs. This could be a genetic change in the next generation. We have drugs that might undergo receptor site change, or that they may synthesize compounds that break down the antibiotic itself. Beta-lactamases are a classic example. Beta-lactams are like penicillin-like drugs, and there are bacteria that produce an enzyme that break that down. And so there are ways that the pathogens can acquire resistance by different mechanisms. We'll also see either this could be done by spontaneous mutation, and that it's a random change so that with each cell division, there's some mutation that occurs in that cell division that renders this change in ability to produce an enzyme or affect a receptor for the drug or something like that. It could also be done by conjugation, and conjugation is probably the scariest thing. The process where one bacteria can introduce chromosomal DNA to another bacterium. We see it with some gram-negatives in particular, that they can transfer multiple drug resistance. And the image of this, if you've ever seen an image of this, it looks like almost like if you're familiar with the concept of a or a jet fighter getting refueled in flight, where the one jet hovers over the other jet in flight and threads the fuel line to the second jet. In a sense, bacteria sort of insert their DNA into another bacteria, and that bacteria then is transferring a lot of genetic information that will promote resistance. That's really kind of a scary thought, but really is a concern for us with antibiotic resistance. We see that the nature of how we use antibiotics affects the likelihood of developing resistance. And so there are some antibiotics that are more likely to promote resistance than others, particularly the broader spectrum agents. And so clinically in practice, you'll hear this term, we'll talk about antimicrobial stewardship. And this concept is for us to not use broad spectrum agents unless we have a really good reason to use them. If you don't need antibacterial drug, don't give it. If you do need it, if you have isolated the pathogen, then pick an agent that just hits that pathogen and nothing else. Would be, at least that would be ideal. We also look at the nature of drug, both what dose we use, but also how long we use that drug. And so we'll find that we often are in an age now where this stewardship, this guarding the arsenal we have for antibacterial agents is particularly necessary because of all of the resistance that we see in practice. A piece of information that's going to be helpful for you is something called an antibiogram. And most healthcare settings, most labs will produce one of these for a community practice every year or so, sometimes more frequently. And so, for example, a large hospital system may produce their lab will tally all of the cultures they received in the prior year. They'll look at all the urine samples. They'll look at all the blood samples. And they'll look at what is our pattern of resistance for different pathogens, and what's our sensitivity versus what's our resistance patterns. And then they will publish this data that you as a clinician now can see that what is our rate for methicillin-resistant Staph aureus in our community. So if you see a patient who's likely to have Staph aureus, is it a 20 or 30% chance that is going to be resistant to methicillin, or is that a 40 or 50% chance? And that may influence which agents you choose to pick. Empirically, what you decide to start therapy with until your cultures are back. Now, when you got to keep in mind, if we need a patient who's really sick, we need to start the antibiotics today. Well, you're going to get your cultures first, if it's something that you can culture, a blood culture, a urine culture, a sputum culture, or whatever, a wound culture. But you may, because the patient is so sick, you have to start therapy now, and you know you won't get that culture result back for 48, 72 hours. Then you're going to choose the therapy empirically based on what's the likely pathogens you're going to see at that site of infection, and then what's your community track record for these antibiotics? What's the likelihood in your community of whether that antibiotic's going to work or not? And you're going to use this antibiogram to help you decide that. You've got to worry about when we use some of these agents, the changes in flora that we can see. We could see the normal flora we expect, normal flora in the GI tract, for example. We expect normal flora in the vaginal area, in the oral cavity. And the problem is that when we use broader spectrum agents in particular, what you have is you wipe out some of those good bacteria, those normal flora, and lo and behold, what you can end up with is whatever is not hit by that bacteria, antibacterial drug, has all those nutrients left for itself, and it grows sort of as a super infection. A common example of this is someone, for example, a woman who is treated for a urinary tract infection with a broad spectrum antibacterial drug, who over the next 4 or 5 days develops a vaginal yeast infection. And why that happens is that you would expect that in the vaginal area you're going to have normal flora, bacteria, as well as yeast. If your antibiotic wipes out a lot of the bacteria that's there, then the yeast that are left have those nutrients not kept in check, and you have an overwhelming yeast infection. That's pretty common. And some of these infections can happen in different areas, and they can be sometimes difficult to manage or treat because they become pretty profound. So how can we look at delaying the resistance of antibiotics, using antibiotics only when we need them, antimicrobials when we need them, using the narrow spectrum agent we can, and the newer antibiotics, reserving those for when the older ones don't work. In fact, you'll find that many drugs in hospital settings in particular are going to be restricted, that you can't use this drug unless you've got a consult by the infectious disease service, or maybe in conjunction with the pharmacy, that the only people who get this drug are folks who have failed other drugs or are not candidates for them. We need to evaluate the need for treatment when there's fewer alternatives in a resistant infection. The cultures with the MICs can guide us. We alluded to that a little bit ago. And in those cases, we may have to treat with pretty high doses, even risking toxicity to the patient with those doses, if that's the only alternative we have that's available for the patient. So really, when we select an antibiotic drug, we consider all of these things. You want to look at which agent is going to have the maximal effect on the pathogen with the minimal effects on the host. You're going to look at trying to identify the infecting organism, the drug sensitivity of that organism, and the host factors like where's the site of infection, what's the immune status of the patient. You also need to look at what you can't use. So your alternative agents might be limited because a patient has a penicillin allergy, a true anaphylactic type ability to produce anaphylaxis with an antibiotic. Or you might have an inability of that drug to penetrate the site of infection. For example, with meningitis, there might be a lot of antibiotics you could consider using, but if the drug doesn't cross the blood-brain barrier, it is not going to work for you. So that needs to be consideration. And maybe there's something unusual about that patient or a concern about their toxicity. For example, you want to use an aminoglycoside antibacterial because that covers Pseudomonas well, for example. But the problem is if the patient has poor kidney function already, then it's going to be very hard to dose adequately the aminoglycoside, and the aminoglycoside is going to contribute to more toxicity to the kidney. So that kind of level of specificity we'll talk about more when we get to the drugs. But just recognize we're considering what the host organ's function is, we're considering their allergy choice, where their site of infection is, what the likely pathogen is, what the sensitivity in your community is for that pathogen until you get your cultures back. Is the host's defense systems in place? Is there something else that's going on with that person that renders this, your choice is somewhat limited for choosing a drug and how you choose that? The lab testing, typically, you're going to typically start in most cases, you're going to start something empirically until the lab results come back. And so the cultures are going to help you decide what to do and refine therapy maybe in 72 hours when you get that culture back, but you need to first figure out what you're going to start therapy with. And so we often start with a good educated guess. You're going to look at all the history of the patient. You're going to look at their presentation. You're going to look at their symptoms, what their presumed sites of infection are. And then you're going to make an educated guess what the pathogens are likely to be and what the community response to different antibiotics are, and then all the things we thought about before. You're going to get the culture, and then the culture comes back in 3 days. If the patient is not responding to the therapy you've chosen, and the culture results suggest there's a different antibiotic that can work, and the one you chose is resistant, then you're going to change to that antibiotic. That's pretty easy to figure out. What gets a little more complicated is if they've responded to the therapy pretty well, but there's a narrower spectrum agent you can use, many clinicians will try to go to that narrower spectrum agent. You could argue, though, hey, the one we've given them works. Let's just keep at it. If it's not broken, don't fix it. The problem is that if you don't de-escalate down to a narrower spectrum agent, you pose the risk for drug resistance developing to a higher degree in that patient. So it's become more common in practice that we're going to use those culture results when they come back to streamline our therapy to pick narrower choice agents over time when that culture comes back. The most common way that labs do these cultures these days is this broth dilution method. That's what we showed you maybe 20 minutes, a half an hour ago with these test tubes with the different concentrations of the drug. But we also use sometimes the older disc diffusion method on a Petri dish. And if you had a microbiology lab somewhere in your practice, or you remember taking a course in microbiology, if you had a lab, you may have actually remembered these, is that you cultured out the bacteria on a Petri dish, and then you put the particular colony over the next Petri dish that had these discs impregnated with different antibiotics and looked for what was called a zone of inhibition. And we still use those tests, but not very much. Disc diffusion is really an older, more cumbersome way for labs to do that kind of testing now. You're always going to consider in the choice what the host defenses are, if they're immunocompromised or not, and what the site of infection is. And can you get adequate amounts of the antibiotic you want at that site? So it's got a lot to do with pharmacokinetics and distribution of drugs. Will a drug distribute to where you want it to go? Other host factors we think of is what's the age of the patient. Are they pregnant or not, or women of childbearing age? They had other allergic reactions. Are there genetic factors that might affect that? And the site, the dose size and duration of therapy also a consideration for us. Sometimes do we choose combination antibiotics or not? That's going to depend, and we'll talk more about the specificity of this later throughout the year when we talk about different treatments. But in general, we try to avoid combination of antibiotics except in some limited circumstances. When we're going to use combination of drugs is when we know that the advantage of using more than one antibiotic outweigh the risks. There might be additive potentiation effects that are seen that the combination of two drugs works better than a single drug alone. A common example is sulfamethoxazole trimethoprim that affect two different ways that folic acid is synthesized in bacteria. So it's sort of a 1-2 punch. We use that commonly together. There are some severe infections where you don't know what you've got. So you've got somebody who could have multiple bacteria, and you don't know which bacteria they are, and they're not covered by a single antibiotic, and so you need a combination of antibiotics to cover that. Or you have mixed infections, sometimes severe infections until you get the cultures back. You can't risk going 3 days with the wrong choice, and so you might pick until the cultures come back a more aggressive combination therapy. There are some cases where the combination therapy is used to prevent resistance, and this sounds like the exact opposite of what we just told you. When we have situations where a single pathogen is known to mutate in the presence of a single antibiotic, we sometimes use combination therapy. And there are only a couple of examples of us doing that. We do that always with tuberculosis. So tuberculosis we treat with combination therapy. We do this with a particular pathogen called H. pylori, which is associated with GI bleeding risks. We also do it with occasionally other bacteria, and then we do it commonly with HIV, where we typically won't use a single agent, but use a combination or a cocktail of agents as an antiviral therapy component. There are times when we might get by with lower toxicity instead of a full dose of one drug that might be, for example, toxic to the kidneys. A lower dose of that drug in combination with the second drug maybe is associated with some benefit, or there might be some enhanced bacterial action. Those last two examples we sometimes use for some cases of endocarditis, for example, a lower dose of an aminoglycoside antibiotic like gentamicin or tobramycin on top of a beta-lactam antibiotic like a penicillin for the first couple of weeks of endocarditis, which that lower dose of the aminoglycoside allows it to be less toxic to the kidney, and also the combination is more effective for some types of endocarditis than not using them. But there are disadvantages whenever we use combinations. We worry about toxicity and allergic reactions to more than one drug. We could have antagonistic effects happening, the risk for superinfection, as we alluded to earlier, for selection of drug-resistant bacteria, and sometimes is the case when we use that, and increased costs. So we weigh the risk and the benefit of those combinations or not. In practice, you are going to, when you're treating a particular condition, you're probably going to have a set of practice guidelines that are going to be available to you that are going to guide your general decisions of why we use a combination or a single agent. What's our first-line agent? What's our second-line agent for the common presentations you'll see? But then you have to apply that to the patient you have in front of you and customize it based on their immune status, their allergy history, their presentation of how severe their disease is. We sometimes use antibiotics prophylactically. We do it prior to surgery, particularly when surgical procedures are going to be a higher risk for infection. We use it for patients at risk for bacterial endocarditis, for certain patients who have neutropenia, particularly after certain courses of chemotherapy. Occasionally, although less commonly, we will use them for people who have recurrent urinary tract infections, sometimes for types of influenza. We don't use that much anymore. For following exposure to certain sexually transmitted infections, and after exposure to HIV, to TB, to meningitis. So there are discrete times when we use an antibiotic when we actually don't necessarily know if we've got an infection, but we think the patient is at high risk of developing an infection, and so we give a dose of a drug, maybe a lower dose or a lower duration of therapy in these circumstances. There are lots of misuses of antibacterial drugs as well, trying to treat something that is not treatable, for treating a fever of unknown origin, using a dose that's too high or too low, not getting culture information. And one big one is if you have an abscess or a wound going on, you need a surgical intervention to drain that abscess, to debride that wound, and you need surgical management as well, that the antibiotics in those circumstances won't work as well as effectively. There's a large concern I think we have over the last couple of decades for overuse of antibiotics. Certainly, we can see that the issue in animal feeds and in farming, there really is risk for using antibiotics in those arenas that pose a risk for the whole population at large for resistance, for which the benefit is primarily a financial one. And so that's pretty clear that practice is probably not in our long-term advantage as a culture. But we also see overuses of antibiotics in practice. There's been study after study that indicated this. We see patients coming in. Patients really feel unsatisfied if they don't walk away with a prescription. They might have a viral infection. They walk away with a prescription for an antibacterial drug. And that's really something you look to avoid. We see that over the last couple of decades, since there's been a concern for this, we see a drop in antibiotic prescriptions when there's been really a large amount of education to providers. The benefits for using antibiotics should be avoided. So we see in some states a big drop in antimicrobial use over the last couple of decades, where in other states we see that's less so. There's also a talk about using probiotics, and the debate and the data for probiotics isn't quite as strong as or robust as we'd like. These are using live organisms that are sort of good gut flora, for example, to normalize microbial balance in the gut. And study after study has been done, and some studies have indicated really good benefit for probiotics. Other studies have said, hey, no, they're not really that great. And so you'll find a study all over the map about the benefits and risks of probiotics. Here's one study that sort of looked at how well probiotics were preventing a really serious gut infection associated with antibiotics, is Clostridium difficile. And in this graphic, you can sort of see that to some degree, this analysis indicated that perhaps the risk for C. diff was a little lower for folks who use probiotics during antibiotics than not. But you'll see that most of the studies themselves not as strong, that they crossed that center line statistically, meaning they weren't clearly demonstrated beneficial compared to placebo. And there are some studies that actually suggested that while they also crossed the center line, that maybe they offered harm as well. So the concerns with probiotics and what the risks are, we worry about someone who's immunocompromised, who's had recent chemotherapy, have on immunosuppressive meds, or folks who are vulnerable or have IV access, particularly central line IV access. Those are folks for whom we don't want to use probiotics, and we don't even want to use it if they're in a hospital with their roommate, if they're not in a single room. So there's a lot of meds that will suppress immune status, and so in immunocompromised folks, we really want to avoid these. There have been actually infections that have been reported from use of some probiotics, and so that's sort of the downside. So there are a number of considerations, and sort of one of the sort of Bibles associated with pharmacotherapeutics is a text called, is authored by DePiro, and their basic principles are, and I think clinicians agree with this, getting cultures before we start antibiotics whenever that is reasonable to do and possible to do, basing empiric therapy on the likely pathogens for the site. That's also consistent with the patient history, looking at the local antibiogram. If you have a patient with a type 1 hypersensitivity reactions with a class, you want to avoid that class or anything closely related to it. We need to adjust their dose for their usually kidney function, sometimes liver function. You want to manage their drug interactions, and you want to limit combination therapies unless there's evidence that the benefit outweighs the risk. In cases where combination therapy makes sense is polymicrobial infections, when there's a known synergistic effect, or when it's a clear goal in preventing resistance. What you want to monitor for when folks are on antimicrobial therapy is you want to look at a resolution of symptoms. So you want to look at their temperature, their white count, their erythema. You want to monitor also for adverse effects. When your culture results come back, you want to streamline therapy, convert them to oral when that's appropriate, and some of the newer recommendations and guidelines we'll see, and depending for antimicrobial stewardship management, you'll hear much more about in the next couple of slides, and more so in the next few years, over the next year, is our shorter durations of therapy. And we'll see some of the guidelines, for example, nationally look at shorter durations than we used to use for therapy. The other thing is that if after a couple of days someone is actually not responding in the way you would have expected, you want to look, do you have the right diagnosis? Are the levels right? Is the dose right? Are they immunosuppressed? Do they have an abscess that needs draining? Is there drug resistance? Is there something else that's contributing to that? All right, let's talk about some principles we'll talk about now is the antimicrobial stewardship. And many of these initiatives come right from the Center for Disease Control, the CDC, and their recommendations over the last decade or two have really been at the center of trying to prevent drug resistance. And so when you're looking at protecting patients from antibiotic-resistant infections, part of the issue is to avoid instrumentation when that's possible. Avoid indwelling Foley catheters, for example. That's a big issue. Avoid excessive instrumentation when you don't need to. If you don't need to intubate a patient, for other reasons, we probably wouldn't intubate them either, but that poses a risk for pseudomonal infections when you instrument a patient. Probably the biggest thing you can do is wash your hands. Good hygiene, wipe down your stethoscope before and after seeing patients. Washing your hands, good hygiene practices. And also the third issue is improved antibiotic use, narrow spectrum agents, shorter duration of therapy, not using them when the benefit is really minimal. The Center for Disease Control has targeted a number of things over the next few years and have had done so for almost a decade. Probably the biggest of which are listed at the top of this slide is to reduce the risk of or the threat of Clostridium difficile infection. That's a major concern. They're also concerned about carbapenem-resistant Enterobacteriaceae infection in hospitals. And those are sort of two main concerns. The third is the maintaining a low degree of ceftriaxone-resistant Neisseria gonorrhea, which really kind of jumped up initially mid-decade. There's other serious threats they look at too: pseudomonal infections, MRSA concerns, multi-drug salmonella infections, multi-drug TB is a concern with them as well. Antibiotic-resistant invasive pneumococcal infection in young kids under the age of 5, which is a concern for otitis media treatments as well, which poses an increased risk for that. So a number of things that are concerns that the CDC looks at. Their recommendations to avoid concerns or improving antibiotic use to combat resistance of antibiotics come from the recognition that about a third of prescriptions are probably unnecessary. And their recommendations for antimicrobial stewardship is really threefold, or the way to improve things. One is to have an antimicrobial stewardship program in place, which includes, among other things, watchful waiting as opposed to starting antibiotics when the patients, when that's clinically appropriate to do so. Providing feedback to providers about their antibiotic prescription patterns and how that adheres to national guidelines, and to make sure that there's a good relationship and talking about antibiotic needs between patients and their providers. Defining antimicrobial stewardship, there are a number of different definitions, but really we consider antimicrobial stewardship as a coordinated set of interventions to improve the appropriate use of antibiotics and to really reduce the risk of drug resistance being developed. The CDC kind of is clear about how to do that. Really some of the benefits are improved patient outcomes, reduced Clostridium difficile infections, improvements in rates of antibiotics susceptible to targeted antibiotics, and optimizing the way we use resources. Typically, most antimicrobial stewardship programs are done in acute care settings. Usually there's an ID specialist in conjunction with maybe somebody in the pharmacy who does that jointly. There are a number of CDC recommendations, and some of them are listed here. We'll talk more about these when we get to the specific situation for these conditions, but these are examples of guidelines that you'll see for how to use antimicrobials. So, for example, for rhinosinusitis in adults, there are recommendations the CDC makes about who are candidates for antimicrobial therapy versus who are not. You'll see listed here in the next few slides. Here's an example of management of uncomplicated bronchitis and the role of antimicrobials from the CDC. Some upper respiratory tract infections, which could be a common cold, and how to manage those and not use antibiotics, of course. Pharyngitis and its management. And also for adults, acute uncomplicated cystitis. And the footnotes for the adult recommendations. Here are some pediatric recommendations. Acute sinusitis management in pediatric. Guidelines for otitis media. We'll talk much more about these. A very common, if you work in pediatrics, otitis media, a very common thing you will see in practice. and important to look at when and when not to give antimicrobials for that. Pharyngitis, also important with risk for strep throat, for example. When do you initiate antibacterial therapy versus when you hold off? Also, how to deal with common cold or other upper respiratory tract infection. And bronchiolitis in really young infants to under the age of 24 months particularly. Also, urinary tract infection recommendations in pediatrics. And finally, the footnotes for these. So in a sense, we've covered in a little over an hour some of the basic things to think about with principles. We're going to come back and talk about, in the next slide deck, the antibacterials. We'll talk more about antifungals, antivirals in the third. And finally, in the fourth, we'll look a bit about vaccine use. Okay, very good.